To chair this session, we request Dr. Sendil Kumar sir, Dr. Vikram sir to come to the dais.
As Anand gets ready, it's my proud privilege to introduce Anand to you. Anand is a professor in the Department of Surgical Oncology presently at Adia Cancer Institute. He heads the Uro-Oncology Division and the Musculoskeletal Oncology Division. An excellent orator, has a good humor sense as well. There are more times that we have fought than actually we have agreed upon. This is one time I guess I'll have to say whatever he says is right. Anand, over to you.
Yeah, so I think a lot of uro-oncology is what people before me have already dealt with. They've dealt with the immunotherapies, the cisplatin, and so on and so forth. And fortunately, it's a little intimidating for a surgeon to come and speak in front of nephrologists. You know, you're all good internal medicine specialists, you're all nephrologists. And for me to be able to speak to such an august audience is really, frankly, it's a little bit intimidating. But, you know, I know that you've heard about possibly everything that I'm going to speak with, but this is the surgeon's perspective on what we see. In the Cancer Institute, the uro-oncology is a very dedicated unit. Most of the patients that we see there, whether they are metastatic, non-metastatic, whether they are on chemotherapy or immune checkpoint inhibitors or whatever treatment that they are on, they'll all be mostly seen not only by the medical oncologist, but also by the surgical oncologist. In fact, I'd end up seeing most of these patients in addition to what the medical oncologist would see. So these are my perspectives on what is it that I have learned. A lot of it might be repetition here, but you know, you should, you know, just bear with me, because these are the surgeon's perspectives on uro-oncology and what I see. So the flow is what have I learnt on immune checkpoint inhibitors. Of late, we have a lot of patients on ICIs, on chemotherapy, surgery. What do we know about individual cancers? You know, what is MDT and how do we conclude with this? You know, how does a nephrologist work? As you would be surprised to see, but a lot of patients get diagnosed outside. Patients have hematuria, they have something else, they have microscopic hematuria on evaluation for something else, get a scan done, get an ultrasound done, and come to the urologist. Detection of mass done for other things, and then they come to us. That's where it is. Nephrologists often encounter patients with renal masses or complications stemming from urological cancers for various other reasons, and then they come to us. As we all know, as of date, the commonest indication for renal cancers and bladder cancers presenting to hospitals are incidental masses detected during surveillance or treatment for something else. Understanding the basics of uro-oncology is crucial for nephrologists to provide comprehensive care, especially for early detection, renal prevention strategies, and managing the nephrotoxic effects of these treatments. So early identification and referral can significantly impact the prognosis of these cancers. You play a key role in managing the renal aspects of cancer treatment, such as nephrotoxicity, and as was already said multiple times today, collaboration between the urologist, the oncologist, and the nephrologist is essential for optimizing patient outcomes and making a fundamental understanding to uro-oncology. So just a slide here. You know, this is the incidence from the Indian tumor registry that was published from Bangalore. If you look at the annual change for selected cancers, if you look down there, the number of prostate cancers has actually increased 6% among all cancers among all cancers from the Madras Metropolitan Tumor Registry. So the urological cancer incidence is also increasing, which also concomitantly infers that the need for nephrology services to treat these urological cancers, which are increasing in incidence, is also of paramount significance. There's a wonderful paper by Aisha Sheikh from the Memorial Sloan Kettering on immunotherapy in cancers. What have I understood about ICI, checkpoint inhibitors, and cancers? So why does it happen? Because it's not excreted by the kidney, the clearance occurs by proteolytic metabolism. They have a long shelf life and interstitial injury happens. How frequently does it happen? Multi-center retrospective studies say that the reported incidence is about 2 to 5%. We've not evaluated that at the institute. Maybe that's thought to evaluate. We have right now about 100 patients on ICI for urological malignancy alone. Maybe we can look at our incidence. Single center studies have reported a much higher incidence. How do you diagnose it? The kidney biopsy is the gold standard for establishing this. How do you manage it? Most commonly, you need to withdraw ICIs and seize any known agent to cause this.
We call upon Dr. Edwin Fernando, sir, to enlighten us about causes and management of hypertension in patients with malignancy.
Edwin needs no introduction. He's a very popular speaker for most nephrology and critical care meetings. So please go ahead, Edwin. Hypertension in cancer.
Respected chairpersons and distinguished audience here, thank you very much, Rajiva and the Triple M team, for calling me over. And over the next 25 minutes, I shall be talking to you about certain aspects of hypertension in cancer. I bring to you warm greetings from the Government Stanley Medical College. Cancer accounted for approximately 9.6 to 10 million deaths in 2023, which means every day we lose about 500,000 patients due to this disease. There have been great improvements in the diagnosis as well as the management of patients with cancer. Newer drugs that are available have only increased the problems of cardiovascular complications. And the cardiovascular disease is one of the most common cause of morbidity and mortality in these patients, ranging from heart failure, coronary artery disease, valvular heart disease, and hypertension. In this study published in 2006, if you look at the relative risk of severe or disabling health conditions in cancer survivors, you will find that congestive heart failure and coronary artery disease play a major role. In this 10,000 odd cohort of childhood cancer survivors who are compared with their siblings, you can obviously find the blue line there showing that these patients had major cardiac events compared to their siblings. So these are childhood cancer survivors. And if you look at this large cohort of about 33,000 odd patients, again looking at the survivors of cancer, hypertension is frequently underdiagnosed and undertreated in patients with cancer and those who have undergone therapy for cancer. This is again a distribution of childhood cancer survivors, nearly 571 of them with normal and abnormal BP. So this is a sunburst chart, and the outer chart, the outer ring, shows that nearly about 20% of patients never had hypertension diagnosed, and the red charts show that mortality accounted for this. In this metabolic syndrome and cancer project, is there an association between blood pressure and cancer risk? So these were about 7 cohorts in different countries, and what we found was a positive association for cancer mortality. So there is a small increased cancer risk overall in men with elevated blood pressure and higher risk for cancer death in men and women. So cancer and hypertension is a complex interplay of many factors. We have the traditional conventional risk factors for hypertension, aging, diabetes, smoking, etc. Then you have the anti-cancer therapy, the newer ones that produce cardiotoxicity, in addition to producing nephrotoxicity and vasculotoxicity. And then you have the indirect effects of cancer, deconditioning, weight gain, pain, stress, anxiety, painkillers, and all this contribute to hypertension and increase the risk for cardiovascular disease and mortality. So there emerges a specialty called oncohypertension, where there are different players: paraneoplastic hypertension, anti-cancer drugs, adjuvant therapies, radiation nephropathy, NSAIDs, EPO, calcineurin inhibitors, all causing hypertension, which requires a multidisciplinary approach, specific management, comorbidity management, and it is more difficult and more expensive to manage these patients. So you read any textbook, you will find this list of drugs with pro-hypertensive properties. The most important one is the VEGF inhibitors, which bevacizumab and the TKI inhibitors that have shown to have a high incidence of hypertension post-transplant, post-cancer chemotherapy. And then you have the PARP inhibitors, the MEK inhibitors, and the RET kinase inhibitors. All of them, almost all the newer drugs have a pro-hypertensive effect. And if you look at the hypertension, the various classes of cancer therapy, again you would find that the VEGF inhibitors are the ones that have maximum about 20 to 90%. And even a platinum-based therapy that all of us have been used to, cisplatin, carboplatin, etc., long-term has been found to have hypertension as a side effect. So this beautiful chart would explain how the multiple drugs, starting from steroids, the androgen deprivation, CNIs, PARPs, radiotherapy, VEGF, red kinase, all of them through multiple mechanisms on the renal sodium and water handling, effects on the renin-angiotensin system, the sympathetic and parasympathetic tone, the reactive oxygen species, vascular anatomy, alteration and vascular dysfunction, endothelial dysfunction, all cause blood pressure through different mechanisms but having a different interplay. VEGF signaling pathway inhibitors, this is the one that is most commonly spoken about when we talk about cancer. So we have the bevacizumab, then we have the anti-VEGFR monoclonal antibodies, the multi-target TKIs, the soluble VEGF decoys, all of them by a combination of reduction of nitric oxide, increased endothelin, endothelial rarefaction, podocyte damage, and multiple mechanisms that play and produce hypertension and proteinuria. And if you take these VEGF1I related cardiovascular toxicities, so almost all the monoclonal antibodies as well as the TKIs, all of them cause hypertension up to about 20%. Radiation induced hypertension can happen when there's an increase of 15 millimeter systolic, 10 millimeter diastolic, or a 5 millimeter increase in mean arterial pressure. Now, when patients who underwent radiotherapy were followed up, nearly about 50% of patients developed hypertension. While on treatment, post-treatment visits, some of them remained hypertensive and nearly a quarter of them prescribed additional antihypertensive drugs. In abdominal radiation, it is believed to be due to increased atherosclerosis of the renal artery producing renal artery stenosis. And in head and neck radiation, it is baroreflex failure. So how do you assess patients with cancer? BP assessment in the office setting, and in clinic, of course, it's subject to a lot of error, anxiety, individual techniques, equipment, measurement method, time constraints, and then patients will be very anxious. They would have temporary medication like NSAID, steroids, and there's a high prevalence of white coat and masked hypertension. So it's important that in patients whom we are not able to diagnose clearly, to use ambulatory blood pressure as well as home blood pressure monitoring. When to start antihypertensive therapy? If the BP is more than 140, new onset after treatment of cancer, then you start therapy. Or if there is a substantial increase of more than 20 millimeter of mercury in systolic BP after anti-cancer therapy, then you should start treatment. Of course, if somebody is having pre-existing other comorbidities like cardiovascular disease or diabetes, then BP should be started at, the drug should be started at 130/80. So this is the European Society Guidelines 2022 on how to manage arterial hypertension in patients receiving cancer therapy. So again, we don't have very clear evidence. Most of them are only level C evidences as to how to treat these patients with oncohypertension. And depending on the outcomes, suppose somebody's got a metastatic cancer, and if somebody's got a shortened half-life, a life expectancy of less than a year or so, then you may even consider not treating this group of patients. So how do we go about? If you have somebody with a cardiovascular risk factor, pre-existing diabetes, hypertension, etc., then you looking at a BP of 130/80. If it is below that, you start anti-cancer therapy. If the BP is more than 130/80, you have to optimize the BP treatment. What drugs you use, again, we'll come to it. And if the BP is more than 140/90, and it's with pre-existing cardiovascular diabetes and CKD, then you start treatment. Now, you start monitoring the blood pressure weekly for the first cycle, 2 to 3 weekly thereafter. And then if the BP is well maintained, you continue treatment and complete therapy. And if the BP is on the higher side, you have to optimize the BP therapy. What drugs would you use? ACE inhibitors, ARBs, CCBs, beta blockers, diuretics, MRAs. And if the blood pressure goes very high, you can hold anti-cancer treatment, give a chemotherapy holiday, and monitor the BP. And if there is a hypertensive crisis, then you will have to hospitalize the patient. No RCTs have been done to show the superiority of one antihypertensive drug over the others. Again, if you look at what drugs you would use, ACE inhibitors, ARBs are the first line. Dihydropyridine CCBs are the second. Combination therapies can be used, and very strongly diltiazem and verapamil are not recommended to treat these patients. However, if you look at the levels of evidence, it's quite poor. It's only B and C level of recommendation evidences. So once you complete anti-cancer therapy, again, it is very important to keep monitoring the blood pressure and optimize the BP treatment. Particularly if you are using a VEGF inhibitor, then you'll have to keep monitoring the blood pressure, and if the BP is uncontrolled, we'll have to optimize the blood pressure before we start therapy. And though in large meta-analysis only about 30% of patients develop hypertension, in off-trial clinical use, nearly 45 to 80% of patients on these drugs develop hypertension. And you can hold the VEGF till the BP is controlled, or on VEGF therapy, if the blood pressure shoots up more than 160, 100 or more than 180, 100, or there's a hypertensive crisis, then you'll have to hold the drug and discontinue the drug. Then depending on the other comorbidities, you can use the drugs as has been recommended earlier. You're all aware of this. Very, very important to look at antihypertensive drugs and anti-cancer drug interactions. These are very important. Beta blockers interact very badly with the TKIs, and they can produce additional bradycardia. They can potentiate QTc prolongation. Loop diuretics can actually worsen cisplatin nephrotoxicity and ototoxicity and cause worsening of QT prolongation with TKIs. CCBs, again, as I mentioned, it is recommended to not use the non-dihydropyridine calcium channel blockers like verapamil and diltiazem. Potassium sparing diuretics, we are all aware of the MRA and the anti-androgen receptors for hyperkalemia. And ACE inhibitors have a higher risk of angioedema with mTOR inhibitors. What is the target BP goal in patients with cancer? Again, cancer patients have been excluded from all large BP trials. So use the best available guideline as of now. And if there is an estimated 10-year atherosclerotic cardiovascular risk of more than 10%, then you'll have to probably target a BP of 130 by 80. So we need RCTs with focus on optimal BP goals and management in patients with cancer. During cancer treatment, again, monitoring of blood pressure is very important. We must teach the patient to have home BP monitoring. Acute rise in BP may happen, especially the VEGF inhibitors. And if the BP remains within normal limits, then you can decrease the frequency of monitoring. Long-term follow-up is also very important. Hypertension due to the BTK inhibitors can occur several months after initiation of treatment and be persistent. Cisplatin can persist in the bloodstream for up to 20 years after drug exposure and can lead to late onset hypertension. And after discontinuation of the VEGF inhibitors, BP may suddenly dip down, so this may require a rapid de-escalation of antihypertensive medications. Are patients with CKD more prone to develop malignancy? These are two large trials. One is a quite recent one. And if you look at this red here, whatever be the type of cancer, you're seeing a sizable number of patients. In studies, it has been shown about 13% of patients with CKD can develop hypertension. Of course, the last two are urothelial malignancies and renal cell carcinoma, where CKD can happen if you're going to take away one kidney. And when somebody develops a renal issue, identify what is it. Is it an AKI or a CKD or a glomerular disease? What is the etiology? Look for electrolyte imbalance, drug-drug interactions that I mentioned, any associated comorbidities, dose adjustment of the drugs by the level of GFR, and sick day rule implementation for ACE inhibitors, ARBs, diuretics, and SGLT2 inhibitors. So this is the recommendation of using the GFR whenever you're taking a drug. Dr. Mani, our senior nephrologist, used to tell, there's nothing wrong in referring for a drug dose in front of a patient. Absolutely nothing wrong. He used to say this many years back when Google was not there. Now all of us have Google, and all of us do look at drug dosing. So we look at the eGFR, and then you can look at what dose, what are the drugs that you can give at a full dose, where you require dose modification or use an alternative protocol. So depending on the GFR, one can decide what drug you want to use or use alternative drugs. So up to a GFR, let's say less than 15, we avoid a sizable number of drugs and look at alternative drugs. So this is a beautiful VA made by our colleague Kritika Mohan. So cancer drug dosing in CKD and dialysis. So what has been suggested is to use the Cockcroft-Gault formula, which for drug dosing, this is supposed to be the best because there have been some conflicts about the use of the CKD-AP or the MDRD equation. Then we'll have to look at whether the patient is on any form of dialysis, which may interfere with the drugs, and then look at patients, the group of drugs that require drug dosing, the classic chemotherapeutics, targeted therapies, and the immune checkpoint inhibitors. So if the GFR loss is established, it is imperative for the clinician to be aware of the kidney disease that may require modifying dose of chemotherapy, targeted therapy, and immunotherapy. And again, which drug you would use, antihypertensive drug you would use along with the GFR. As nephrologists, all of us know this. So it's worthwhile looking at the chart once again. To repeatedly look at it, then you become good at it. So all this calls for a clarion call for planning a multidisciplinary onco-hypertension care panel, where it's not just the oncologist, but the nephrologist, the cardiologist, the primary care physician. And then we need the palliative care people, the pharmacist, social worker, nutritionist. All of us have to join hands to deal with this group of patients. What are the future directions in onconephrology, oncohypertension? Directions on more specific antihypertensive drug treatment targeting the pro-hypertensive mechanisms, more effective treatment of the anti-cancer induced hypertension, implications for monitoring of BP and treatment thresholds before, during, and after treatment of cancer, and development of guidelines on blood pressure monitoring, treatment thresholds, and long-term follow-up specifically for cancer patients and the survivors. So to sum up everything, I would put this in a single slide here. Hypertension is the most common cardiovascular side effect of anti-cancer drugs, prevalent in about 40% of patients in all cancer, especially the ones, the VEGF inhibitors and the TKIs. So we look at the traditional risk factors, and then we look at the traditional chemotherapy or whether the novel drugs, and the indirect hits of cancer therapy. And the management would include optimal BP control, looking at drugs that can be safely used, maintenance of blood pressure, tailor the drugs. And the first line agents would be ACE inhibitors, ARBs, dihydropyridine calcium channel blockers, thiazides or thiazide-like diuretics. So this concurrent management of cancer and hypertension involves multidisciplinary approach. So I would stop there and I leave you with this question. Cancer and kidney, dangerous liaisons, or the price paid for progress in medicine. Better drugs, better targeted therapies, more cardiovascular complications. I stop there and thank you for the patient listening.
Thank you, Edwin, for a lucid talk. I just have two questions. See, you highlighted first-line agents, a group of drugs. Do you prefer a particular group of medicines for a particular cancer? Because some of the antihypertensive therapy also can increase the carcinogenicity.
Right.
Okay, so
I was looking at this at three different aspects. Somebody with hypertension, can they develop cancer? So there has been some evidences, though a cause-effect relationship
that
is
is
not
only
been
from observational
proven.
studies.
Yes, correct. Number two, antihypertensive drugs. We all know a couple of years back, the ARBs, because of the nitrosamine group, were thought that whether they could be tumorogenic.
It is more of manufactural flaw.
Yes, and that was proven by another large meta-analysis at the Lancet that showed that these drugs are quite safe. And then you have this particular group of people with cancer, and then who can have the traditional risk factor of cancer, which can get hypertension, which can get worsened by these drugs. Again, as I said, which is the best drug to be given for a patient? The oncologist takes a call, depending on his immunohistochemistry reports, the metastatic spread, etc. But then one has to, as I said, it's a multidisciplinary approach. Somebody could have diabetes, diabetic kidney disease, or some other form of CKD, and this patient could develop cancer. And CKD patients also have a small increased incidence of cancer. So I think it's teamwork, and everybody has to sit down together and decide which is the best form of therapy in order to take care of his cancer as well as to take care of his other complications that happen.
Yeah, we have seen quite a few in the last 3 to 4 months.
Yes.
VEGF induced TMA.
TMS.
So that is one cause for accelerated hypertension and worsening of presence as RPRF. Right. So in that situation, whether you stop the medicine.
Yes, I think that's the most reasonable thing to do, will be to stop the drug, and then, because TMA could be disastrous for the kidney, as you're all aware. So at that point, I think we will have to stop there and then take a call at a different group of agents.
Are there any drugs, Edwin, antihypertensives you don't use at all in these patients? Now, from what you showed was most drugs are useful.
Yes.
And what we use for hypertension generally can be used for these patients.
Right.
Are there any specific groups of medicines you don't like to use?
Again, the level of evidence only C, but they recommend that non-dihydropyridine beta blockers, calcium channel blockers, like diltiazem and verapamil, to be avoided in this group of patients. While otherwise it's ACE inhibitors, ARBs, with dihydropyridine calcium channel blockers, beta blockers. Again, beta blockers have some interactions with certain drugs.
In an acute emergency with hypertension and one of these drugs which you talked about, suppose a patient comes with 220, 140 and with a hypertensive emergency, is there any other, or is that the usual way we treat it? Or
yes, at that point of time, I think saving the patient from the target organ damage caused by hypertension takes priority over treating his malignancy. So I think it should be the conventional way of how you treat an hypertensive emergency or urgency.
On pediatric onconephrology. It's truly an upcoming and complex subset of onconephrology. So we call upon Dr. Prabha ma'am and Dr. Balasubramaniam sir to chair this session. We call upon Dr. Sukanya ma'am to give the talk on AKI in children with malignancy.
Hello, good afternoon everyone. Dr. Sukanya Govindan. We invite Dr. Sukanya Govindan to talk on AKI in pediatric cancer children. She's a senior consultant pediatric nephrologist working with Mehta Hospitals and also in Madras Medical Mission. The stage is open. I mean, hand over the thing to Dr. Sukanya.
Yeah. Thank you, sir. And thanks to the M team for putting together such a wonderful conference. I think it's a need of the hour with more and more evolving therapies and multidisciplinary care for taking care of these patients. This meeting is very important because I think it's first of all to acknowledge how much we don't know. It's especially very relevant in pediatric onconephrology. And there are huge gaps in my even basic knowledge of oncology, and I've been asked to speak about AKI in pediatric cancers. But in the last couple of years, with our association with Cancer Institute, I've been fortunate to see some of these children with pediatric malignancies, and AKI has been probably the most common indication for which we are called upon. And I'm very glad to give this talk in that sense. And I think we can all accept that we don't know much and then move on and share and learn. So in the next few minutes, I would like to speak about how common is AKI in pediatric cancers, what is the etiopathogenesis, and very briefly about oncology-specific AKI syndromes. How can we improve AKI diagnosis in cancer with regards to children, specific AKI risk reduction strategies, and treatment of pediatric AKI. So AKI in pediatric cancer is much more common than what you would see in adults because of many different factors. Even in the general pediatric cohorts, AKI in hospitalized children is at a higher incidence than compared to adults because of the smaller size, the propensity to use more drugs in critically ill patients, and the many number of interventions that are required in these complex patients. So one of the largest studies of pediatric cancer in children, pediatric cancer looking at AKI, showed that almost 52.6% of them developed AKI in the first year after cancer diagnosis. And almost all of them are in the 50% of them in the first 2 weeks after cancer diagnosis, with the onset of around a median of 9 days. And more than half of them have stage 2 or 3 AKI. So the pediatric AKIs are more likely to be higher stage AKIs also. And also there are many recurrent episodes of AKI. People dealing with oncology patients would know that there's no straight line. There's always one AKI episode punctuated, and then the creatinine comes down, you treat them again, and then there's another episode of AKI and so on. So there are many recurrent episodes of AKI. And as I said, the AKI in hospitalized patients is much more higher than the general incidence of AKI when compared to pediatrics and adults. And a significant number of them are hospital-acquired AKI because of the nephrotoxic medications that we use. Mortality, we all know that AKI confers an independent risk factor for mortality, and that is and it's also true for children with cancer. And also for the severest of the AKI, children in PICO requiring renal replacement therapy, the mortality is almost 50%. So that is the magnitude of AKI in pediatric cancers. So what is the profile of pediatric AKI in cancer patients? Is it there in all cancers? Probably not. The highest incidence is probably in the acute leukemias of the AML and the ALL, and followed by some CNS tumors like medulloblastoma because of the agents that are being used. Renal tumors, although we talk a lot about Wilms tumors and renal tumors, which constitute almost 6 to 7% of the entire tumors in pediatrics, they still, one would think that kidney tumors would be associated with higher degrees of AKI, but rather because of the agents that are less intensive and also less nephrotoxic, which have been used for these patients, they have lesser incidence of AKI. But however, these patients would have long-term loss of renal function, so they'll have chronic kidney disease, hypertension, and proteinuria moving on. The risk is higher as for malignancy, hematological malignancies, lower EGFR at diagnosis, tumor lysis syndrome, more imaging, more CT scans and contrast interventions, obviously because of a lot of chemotherapy agents which are nephrotoxic, and many children undergo for leukemia and lymphomas, hematopoietic stem cell transplant. And also the lifetime risk of experiencing relapse is higher in children compared to adults. There are some basic differences that pediatric cancers would differ from adult cancers, the nature of cancers itself. In children, we have a lot of embryonal tumors in the hematopoietic system and in the central nervous system, whereas in adults, you'll have a lot of solid organ tumors like breast, lung, etc. And children rarely have any of these, and they do not have concomitant medical conditions like diabetes, hypertension. They fortunately smoke less and drink less alcohol. And epidemiology, so, is going to be different from adults, and as I said, the incidence of AKI is anyways higher even in the general pediatric cohort. So the AKI in children would be influenced by the type of cancer, the type of chemotherapy agents that you're using, the type of concomitant nephrotoxic medications that you would use, like in any other patient, like NSAIDs, aminoglycosides, vancomycin, Septrin, and contrast agents and bisphosphonates. There are specific AKI syndromes which could be linked to oncology syndromes, and also specialized therapies like hematopoietic stem cell transplant, CAR T cell therapy, and also more and more in the pediatric setup, we are now using invasive life-saving measures like ECMO and high-frequency ventilation. All of these would confer a higher risk of AKI to these already complex patients. And of course, infections like urinary tract infections, fungal infections, and viral infections would confer higher risk. So the chemotherapy agents, I need not go take you through all of this. I think you had a wonderful session in the morning. But there are many, many effects of, renal effects of these chemotherapeutic agents. The most important would be the ones that are marked here, causing AKI, like TMA, acute tubular injury, or sometimes renal salt wasting or magnesium wasting, acute interstitial nephritis, and also uric acid nephropathy or the crystal nephropathies. So the tubular injury is specifically why the tubules are involved in majority of these agents is because of the high metabolic rates of these tubular cells. And many of these agents are uptaken in the proximal tubule, and then they are converted into metabolites which are possibly reactive oxygen species and which go on and affect your tubules. And because the proximal tubule has many of these transporters which can take in these drugs inside and process them. It is also, other than the kidney factors, there are also many drug-related factors, prolonged drug exposure, direct drug or metabolite cytotoxicity, and combination with other nephrotoxic agents, and also sometimes because of the intratubular crystal deposition, because of the nature of the drug that we are using. But perhaps the most important and the most modifiable of risk factors are these, the patient factors. Age, the lower the age, it's going to be higher the risk because of the improper drug dosing, either based on body surface area or improper GFR calculation, volume depletion, urinary pH, low GFR at onset of previous AKI episodes. I told you that there are going to be recurrent episodes that these patients would be facing. Many polymorphisms in these enzyme inducers, the type of cancer, and many of these renal cancers, children would have undergone an nephrectomy. So cisplatin is the prototype of the kidney tubular toxicity for all of us in onconephrology. That it's uptaken by the renal tubular epithelial cells, and it undergoes modification which results in the epithelial cell death along with inflammation. So it causes an ATIN to result in acute kidney injury, and cisplatin is the most nephrotoxic of all these platinum compounds. I'm only going to go briefly into these specific AKI syndromes. And tumor lysis syndrome, it is well known that there's going to be a rapid influx of phosphate, potassium, nucleic acids. So there's going to be hyperuricemia into your systemic circulation. These individually also can cause renal vasoconstriction and produce low GFR, in addition to having crystal deposition. And we use this Cairo-Bishop definition for the lab and clinical diagnosis of tumor lysis syndrome. The problem one in pediatrics, when you're using this, the Cairo-Bishop uses a creatinine cutoff of 1.5, which might already be high for a child based on their body surface area and their length. So that is something that one might want to use cautiously while interpreting these criteria. Sorry. The risk of tumor lysis syndrome is predominantly seen in lymphomas and leukemias, and children do suffer from these most of the time, and children suffer from this majority of the times. So non-Hodgkin's lymphoma, ALL, AML, rarely solid tumors like neuroblastoma all have a higher risk of tumor lysis syndrome. And the risk of TLS is you're divided into high, intermediate, and moderate risk, a low risk based on what is your WBC count, sometimes the histological type of your lymphoma, whether your tumor is a highly proliferative tumor, whether the tumor burden is higher, and whether it's highly sensitive to chemotherapy agents. And depending on the risk, your treatment of AKI is also going to, or your management of tumor lysis syndrome is going to be stratified in a manner to avoid AKI. So it can be either only IV fluids with or without a hypouricosuric agent, and very frequent monitoring of labs compared from 24th hourly. You might want to do it very frequently, often multiple times in a day when you're having a high TLS risk. The other AKI syndrome is thrombotic microangiopathy. So there are three different types of TMA that one could have, which is cancer-related TMA. The cancer itself per se can produce a TMA. Fortunately, that is very little or very rare in pediatrics, because adenocarcinomas are the one which would cause cancer-induced TMA, and that is not, that is very, very rare in children. But the cancer drug-induced TMA and the hematopoietic stem cell transplant-associated TMA are quite commonly seen in children. And in the cancer-induced TMA, they differentiate into two types, basically because of the difference in outcome and how they are managed. So your type 1 cancer drug-induced TMA is based on all chemotherapeutic agents, but the type 2 is only for VEGF. The anti-VEGF agents do not cause any structural distortion of the kidney. There is no actual structural damage and have a better prognosis compared to other chemotherapy agents-induced TMA. But the risk of TMA is uniformly increased with using of calcineurin inhibitors, like sirolimus, tacrolimus, mitomycin, gemcitabine, platinum salts, and also with a higher grade of GVHD. Also, infections like BK viremia and other infections can increase your risk of having TMA. So the treatment is uniform. You withdraw the offending drug. You sometimes might use plasmapheresis. In some of these conditions, plasmapheresis might not be very beneficial. Dialysis when needed. Treat the hypertension. Often TMA is associated with very severe degrees of hypertension, and some use of eculizumab and rituximab. I'm no expert in TMA with oncology patients at all. Compared to, very thankful for the previous speakers who have already covered this hematopoietic stem cell transplant-induced AKI. What are the different reasons for AKI in these children? And there are many different, it depends on the timing of AKI, whether the early period or in an intermediate period or very late, 6 months after hematopoietic stem cell transplant. The most important is probably the early period, where you can have sepsis, nephrotoxic agents, you can have shock, you can have veno-occlusive disease, and also a high-dose conditioning regimens all can give a individual risk factor, can be an individual risk factor for developing AKI. And also there is a unique, this HSCT-associated TMA is again, it is something that is seen very commonly in the early period after stem cell transplant. Acute GVHD is associated with an increased risk of AKI. We do not see kidney involvement that much in the chronic GVHD. There is direct effects on the kidney. I remember somebody asking about how is the pathology in the kidney looking like when you have acute GVHD in the kidney. There's a lot of mononuclear cell infiltration and T cell infiltration in your peritubular capillaritis, peritubular capillaries, tubules, and glomerular and endarteritis. So there's all the compartments of your glomerulus, everything it's involved in your acute GVHD. It's a T cell mediated injury. And the other specific syndrome that could happen in hematopoietic stem cell transplant, it was mentioned briefly, is the engraftment syndrome. It's again similar to your cytokine release, where you have, after the rapid neutrophil recovery phase in hematopoietic stem cell transplant, you can have many systemic features like fever, non-cardiogenic pulmonary edema, and non-oliguric AKI. Thankfully, I read that it's not very severe and it's easily amenable to treatment. And of course, we heard a lot about the CAR T cell therapy, so I'm not going to go into that. There's also, interestingly, something called pseudo-AKI in children. It's pseudo-AKI in patients receiving certain groups of drugs. And these drugs can also cause true AKI or ATN. So it's very important to differentiate between these two things when you're dealing with patients receiving these drugs. And this actually happens because of interference with the tubular secretion of creatinine. So when it's less, your serum creatinine goes up and gives you a false impression that your creatinine is high because of an ATN or an AKI. So the agent that is, so the test to do in this situation is use measuring a cystatin C, which will differentiate between a true AKI and a pseudo-AKI. So going to the diagnosis of AKI, and this is where we'll all be very cautious because there are different challenges in children. We use the KDIGO criteria, the modified KDIGO criteria for AKI diagnosis. And this almost everybody here in this room is familiar. So we use the serum creatinine and the urine output as markers for AKI. Are these valid? Are these enough? Probably not. Because in a situation of AKI where your kidney function is rapidly changing, serum creatinine is an inaccurate marker of the current status of the child. And the increase is almost only after you have lost 50% of your kidney function. So it is an inaccurate marker. And also urine output marker in children with nephrotoxic exposure, most of them are non-oliguric AKI, so urine output might not be the better marker to tell you that the child is going in for an early AKI. We are using all these criteria for early detection of AKI. We already saw having AKI confers a higher mortality risk. So we don't want to find something very late, so we want something very early. So in these aspects, both of these do not help that much. And do they aid in renal recovery? Probably not. Is normal creatinine okay? Is it the only target for full complete recovery? We all know that there is a lot of subcellular or modifications in your glomeruli and your tubular interstitium after an episode of AKI. Creatinine does not reflect that at all. And also having normal urine output, again, is not at all the only marker for complete recovery from an AKI. And also in a child or even in an adult with cancer, there's going to be many different situations where you can have a baseline CKD over which you're having an AKI, or you're having a completely no kidney disease and you're developing multiple episodes of AKI with some residual kidney damage. In all of these situations, the use of creatinine and urine output is not going to be very accurate. Coming to a bit about GFR estimation, because even in an acute setting, you would be using this for drug dosing in children. Many of these anti-cancer drugs have a very narrow therapeutic index, and inappropriate dosing can either result in underdosing or severe toxicity. In children, it is seen, at least for some of these drugs like platinum-based drugs, dosing based on body surface area confers a higher dose-related toxicity compared to a GFR-based dosing. So it's advised that you use a GFR-based dosing. And GFR estimation is also very important for eligibility into clinical trials and cancer survivorship surveillance, because especially for children, because they tend to live longer after surviving from cancer and their lifetime risk of developing chronic kidney disease is very high. We use commonly the bedside Schwartz formula, which uses creatinine and length or weight, length or height. Again, it is Unfortunately, it doesn't account for poor nutrition, muscle mass, or the cachexia that is associated in cancer, and corticosteroid-induced myopathy, which is also very common in children. And it results in an overestimation of GFR and giving a higher dosage of these drugs. The 24-hour urine creatinine clearance is not at all feasible in children, especially smaller children, because of difficulty in urine collection. And recently, we have this evidence or a better equation called the CKID equation for children, and that also, and that is very useful only when you use it in use creatinine, cystatin C, and your blood urea nitrogen, and many of us do not use that or have less availability of cystatin C. So that might be a problem. So what would one should do for catching AKI early in these children? The conceptual model of AKI, I'm sure many of you are familiar with it. So we now currently diagnose AKI at the stage where there is decreased GFR. But what we would want to do is something where there is increased risk of AKI, and we would also like to know when there is an early damage to the kidney. And these are the two opportunities where we would want to intervene. Do we have any of these markers right now? Some of them are available, but currently what we have, the creatinine and urine output, they themselves are not reliable in children. Add to it, markers like NGAL, KIM1, and interleukin 18 can be surrogates for damage markers in the kidney. And also, these are applied, when applied for children with increased risk of AKI, have an increased utility value. You can't just go randomly do it in everybody. You have to identify an at-risk population. And that's why markers like this renal angina index, especially in pediatrics, is very, very useful in the pediatric intensive care setting. We use this to identify high-risk patients. Whoever has RAI of more than 8 are said to be at a higher risk of kidney injury, and in them we could use these biomarkers to identify early stages of AKI. So how do you interpret these biomarkers in your ICU or in your pediatric wards? So these NGAL is one that is very commonly used, especially the urinary NGAL, because it doesn't involve blood tests. So the urinary NGAL, when it's positive, it says there is kidney damage. So you can have a situation where both your creatinine and NGAL is normal, that says there's no AKI at all. In your hemodynamic AKI, where there is no tubular damage has happened, there's only a transient fall in GFR, your NGAL will be normal, although your creatinine will be higher. So there you know only hydration is enough and there's no kidney damage. In situations where your creatinine has not yet risen, but there is definitely kidney damage, you'll have an NGAL which is higher, but the serum creatinine is not yet risen. So the last two conditions that I said, that is the most important and the most useful way of using these biomarkers in these two situations. We also know that the lifetime risk of having AKD, acute kidney disease, which is persistent kidney dysfunction beyond the 7 days of that would fall under the AKI, until 90 days, beyond which it's called CKD. And more we might be using these biomarkers also to define what is AKD and CKD. So what should one do? This is part of the ADQI conference 2023, which is important for identifying. It gives you a pathway to identify early AKI, and this is very relevant in children, where you can use a clinical risk score. You have the more critical the child, use a clinical risk score like RAI, and use biomarkers in them to identify early. And these biomarkers, what my assumption, or if I were to be an onconephrologist, I would use these biomarkers to identify children who will be at a higher risk of AKI, hydrate them well, avoid other nephrotoxic agents in them, and you can sort of have an AKI care bundle for these patients and avoid future injury. And having every episode of AKI has its own consequences in oncology. So currently, for the treatment of AKI, we only have supportive care, and that is especially very relevant for us because we do not have accurate treatments for AKI as of now, and it's very important that we prevent AKI or at least identify them early. So we practice fluid vigilance, avoid nephrotoxic interventions. There are very few drugs that can claim to be therapeutic agents for AKI. And when all of this fails, we go for renal support or dialysis. The consequences of having pediatric cancer, AKI in pediatric cancer, is many. You have inadequate cancer treatment because of punctuated with multiple AKI episodes, because it influences the type of drugs you choose, the optimal dosing, inadequate supportive treatments, and increased clearance of drugs on dialysis. On top of it, in pediatrics, all these newer agents, there is very little guidance on how you modify them for renal function. Many of them do not include children in their trials, and none of them have included children with low GFR in their trials. So it's very, very important that you understand this before prescribing these agents. And as I said, the consequences among survivors, the lifelong risk of having chronic kidney disease or proteinuria is very high. As much as quarter of them develop kidney function when seen even at 5 years after cancer diagnosis, and 8.2% of these survivors also had proteinuria. So the risk reduction strategies, like I said, are AKI bundles of care, one of which has been used in the Cincinnati Hospital for Children, which sees a huge load of oncology patients. Just by simple 3 interventions, they were able to reduce their risk of AKI by almost half. They replaced piperazolone tazobactam use with cefepime. They used vancomycin stewardship, so they never used vancomycin empirically beyond 72 hours if it's no longer indicated, and they used nephroprotection for intravenous contrast. So these 3 interventions alone almost reduce the AKI risk by 49%, and that's a huge, huge reduction in oncology patients. Avoid hypoalbuminemia or correct hypoalbuminemia before giving tubulotoxic drugs, IV hydration before tubulotoxic drugs, avoid repeated exposures, prolonged exposures, and use renal modified doses whenever possible. And use frequent monitoring, and with available tools, you can either use creatinine, and if at all available, please use cystatin C for these patients. And also, when you're using contrast, make sure that you're not repeating the contrast administration within 72 hours of repeated doses. The type of contrast matters. Use low osmolol, or if not, if available, isoosmolol. And the contrast administration route, if you're using IV, that's better. And avoid multiple injections, and also concurrent nephrotoxic medications. For the non-nephrologist, you could go back and read this paper about the Ninja model, which is to decrease the nephrotoxic medication load. There is also one baby Ninja model. We have some cute names there. But those are very, very effective strategies. There's nothing hi-fi about it. You just look at how much is the nephrotoxic medication load. You monitor these patients more frequently and try and see if you can use alternative agents. That's all one should do to reduce the risk of AKI. The modalities of dialysis, so when everything else fails, unfortunately, some of these children do require dialysis, and the modalities of dialysis are, like in any other patient, would be peritoneal dialysis, intermittent hemodialysis, prolonged intermittent renal replacement therapy, and CKRT, just that it's even more complex in children with cancer and children in general. So the decision is based on the patient age, the availability of a vascular access or a viable peritoneum, the expertise in the center. Not all centers would be easily okay to do a hemodialysis or a SLED or a CKRT in a child. And the indication for dialysis, depending on whether you have tumor lysis, you might not want to do PD, you might want to do a continuous and a more efficient way of clearance. I'm not going to go into other modalities of dialysis into each one of them, but there are specific challenges in children when you come to dialysis, and in our experience in Cancer Institute, we have quite a bit of problems when you're dealing with these very, very complex children. They have already many tubes sticking out, and finding an adequate vascular access, finding an adequate catheter size. The younger the child, and already many of these patients have loss of vascular access, so finding a vascular access itself is an Achilles heel in many of these patients. Having a proper hemodynamic status. Many of our extracorporeal therapies do not have an adequate circuit volume. The extracorporeal volume is too large for accommodating a smaller child, so we often use techniques like priming, saline priming, albumin priming, blood priming, etc. And we many times do dialysis with adult-specific machines. There are no pediatric-specific CKRT machines as of now, and even IHT machines are all adult machines. So all these are challenges when you deal with pediatric renal replacement therapy. But the thing is, perhaps because we do not have the best modalities and the best machines, perhaps the survival is also very poor in children who develop these complications, and the PICU survival for patients requiring dialysis is hovering at around 50%. So these children really, really do very badly. So to summarize, AKI incidence in pediatric cancers is very high, and it's associated with high mortality and the long-term lifetime risk of renal dysfunction. Hematological malignancies, among all the malignancies, have the highest incidence of acute kidney injury. There are many unique AKI syndromes and nephrotoxic agents that one should be aware of. Early and accurate identification is necessary because of all these problems, and a combination of markers is advisable in children. And there are many specific interventions and broad interventions to prevent AKI. And dialysis for severe AKI, it has its own challenges in children, but yet it is complicated by poor survival. Thank you.
The exposition. Just to add, always look for syndromes in pediatric malignancies, like a Fraser syndrome presenting as a steroid-resistant nephrotic syndrome may have streak gonads, which later develop go in for gonadoblastoma. Likewise, Dennis-Drash syndrome, they can develop Wilms tumor. And the other thing is to avoid combinations of anti-cancer drugs with vancomycin and aminoglycosides. And maybe in future, use of biomarkers may help us to detect AKI earlier.
Yeah, thank you for a wonderful talk, specifically highlighting pediatric AKI, vis-a-vis adult AKI. The floor is open for questions from the audience.
Nephrogenic diabetes insipidus with methotrexate because of doubling the dose. So once you reduce the dose, the polyuria settles down and the diabetes also goes off.
Especially many of these tubular toxicities are dose dependent. So looking at the dose once you have a complication is very useful, I think.
Yes, yes.
Yeah.
Okay.
Hello. Good evening, good morning, wherever you are in the world. I'm Ken Archivari. I'm at Northwell Health. I'm a professor of medicine. My job today is to introduce you to the field of onconephrology and how that came to its existence. And hopefully this will inspire the creation of further work in onconephrology in India. These are my disclosures, really nothing that is pertinent to this talk, but I did find and be the president of the American Society of Onconephrology. I do always start with special mention to my mentor who inspired me in this field. When I was a trainee at Weill Cornell, we used to rotate through Memorial Sloan Kettering, and one of the nephrologists there, the chief of nephrology there, who's still there, really got me excited about the field that combines cancer and kidney disease and electrolyte disorders, and that's Dr. Carlos Flombaum. So I have a special place for him because this is where it all began for me, where I trained. Onconephrology, we'll talk a little bit about history, we'll talk about the different syndromes that onconephrology entails, and then eventually focus on the future of onconephrology in India. The cancer is a common global problem. It's estimated that more than 1.8 million new cases of cancer get diagnosed year in the US at least. Prostate cancer being the most common, followed by lung, and in females, breast cancer and lung. What's happening though is the people are getting better treatments. Oncologists and hematologists have really revolutionized treatment, and as a result, survivorship has improved. So we're seeing a lot of the complications of the kidney because people are living longer. But why onconephrology? This brings us to the specialty of onconephrology, which was created by nephrologists as to take care of patients who have cancer with their complex problems. So list, is long, but it kind of talks about basically anything you see on the cancer ward, from AKI to glomerular disease to obstruction, specialized toxicities of the drugs, TMAs, myelomas, amyloids, tumor lysis, you name it. It's a combination of cancer, kidney disease, and eventually causing sort of specific disorders that you should be aware of. This is a special slide that we had created as part of introduction to Onconephrology Society in 2022 for the Journal of Onconephrology. I think this is useful from a context standpoint because onconephrology is finally getting some traction after starting this in 2009 or so, almost after 10-15 years. So from a research standpoint, there were mostly review articles in 2007, 2010. It's really in 2014 when original investigation started coming about. And then 2017, there was the creation of Journal of Onconephrology, and then finally other journals wanted, things within their journal. In 2005 is when really the first textbook of onconephrology by Eric Cohen was published, and then review articles in 2009, 2011, and then now there's several textbooks on onconephrology with several countries with local societies. Education was mainly reviews and talks here and there, but really 2009 was the first ASN session, followed by the first ASN pre-course in 2019, and then starting 2015, various centers in the US started having yearly onconephrology symposiums, and then 2018 was the first KDIGO meeting, and now there's so many centers around the world doing onconephrology symposiums like yours as well. But that led to creation of the American Society of Onconephrology in 2022. So let's talk a little bit about different things onconephrologists do. One of the things is AKI, and AKI in the cancer patient is important. The mortality is high when you have cancer patients. 40% of critically ill patients with cancer require kidney replacement therapy. And the causes of AKI are variable, right? There is hemodynamic, there is the usual ATN obstruction, but there's all these related causes of cancer that are treatment related. And then there's some stuff that is cancer related, like tumor lysis. So I think I think it's important that people understand the different causes of AKI. Acute kidney injury that happens with cancer drugs can be summarized actually in this figure of the nephron, and I think what I say is you can learn so much nephrology just from onconephrology. And you can see here that all these chemotherapy agents that we use for cancer can have nephrotoxicity, and I think that's another place of so much learning because these cancer drugs are growing exponentially. So being on top of that requires a special expertise. Conventional chemotherapy is your cisplatin, methotrexate, ifosfamide, cyclophosphamide. We know they cause kidney toxicity, and so that's the one area that most nephrologists are familiar with, that they cause kidney toxicity. So this is not unusual to see some of these cases in the ward, but this is not something that is novel, which we knew about this even before onconephrology was developed. It's these targeted chemotherapy agents that we really are seeing a lot more in novel things, like much more TMA, proteinuria, AIN, and significant amount of hypertension with these anti-VEGF or tyrosine kinase inhibitors. There's so many of these, targeted therapies against a specific target, and they will be something that will keep growing and we need to be aware of. So this is to show you that the oncology world is exploding with newer therapies and newer drugs that have revolutionized the treatment of cancer patients in immunotherapy. So it's important that we as a field of nephrology keep up to date. It's hard to kind of keep up track of these things. And that's why the New England Journal of Medicine is not really the New England Journal of Oncology. Immunotherapy, as some of you have spoken about in this symposium, is another big hot topic. It is known to cause acute interstitial nephritis and some glomerular diseases. There's also this rising CAR T therapy where people are using for certain lymphomas and now even myelomas that can cause ATI in the setting of capillary leak syndrome. And then we have these old immunotherapies like IL-2 that people use and that could cause like shock-like symptoms. So there is this growing field of literature on the risk factors, prevention of AKI with checkpoint inhibitors, and that's another field to learn a lot about onconephrology. Obviously, electrolyte disorders happen every time in any patient, but in cancer patients have different causes, different consequences. Ignored 3 ions are the mag, calcium, and phosphate, and there's so many new developments in these cancer drugs causing hypomagnesemia, especially cetuximab. There is drugs causing hypercalcemia, and interestingly, recently, even checkpoint inhibitors can trigger hypercalcemia. There are all these novel therapies causing hypophosphatemia. So something to kind of keep in mind. It reminds you of like some of the HIV era with all these drugs. Obviously, the hyponatremias, hypernatremias, and potassium disorders are important. Again, in the cancer ward, the treatment is slightly different given their volume depletion status. They do also get checkpoint inhibitor induced adrenal disorders, so you have to keep that in mind as well. And certain cancers, like liquid tumors, can cause pseudo electrolyte disorders like pseudo hyperkalemia that we shouldn't forget in these patients. So this is an important slide. I think in onconephrology, one of the aspects that's different than general nephrology is pseudo electrolyte disorders, and a lot of these pseudo hyponatremias that we see with paraproteinemias and IVIG use, hyperkalemia with CLL and severe thrombocytosis, reverse pseudo hyperkalemia with CLL, and sometimes even pseudo hypokalemia. We do see even pseudo hyperphosphatemia with myelomas and so forth. So there's a lot of interesting learning aspects to these electrolyte disorders. Renal cell itself is an important topic within onconephrology because they get nephrectomies and then they're left with CKDs. So that has a whole field that's developed within urology, nephrology, and oncology. So we actually have a nephrologist who specifically focuses on this in the urology offices of cancer patients who get nephrectomies, and they they do have all the same risk factors: hypertension, smoking, obesity, diabetes. So they do have biopsies of the native kidney, of the the non-neoplastic kidney. They find these biopsy findings already in them. So, and these patients get immunotherapy and VEGF inhibitors. So it's important to know about this. One of my favorite topics is thrombotic microangiopathy. It's not truly onc, but heme, but it's an important component because it does bring in oncologists, hematologists, nephrologists, rheumatologists together. And one of them is the way you define these syndromes has been a misnomer. So I think that's another whole area that we need to learn a lot from combining these two fields. So causes of TMA from TTP to HUS, but really more limited renal toxicities from the drugs, as well as hypertension or other causes of TMA. Monoclonal gammopathies is a big one. That is another component of heme nephropathies. And as you know, that a circulating paraprotein can deposit in the tissue and cause amyloidosis or a lot of glomerular diseases like MIDD. Or you can get non-Randall type diseases like we're seeing a lot of PG and MID that's hard to treat and diagnose. We also get tubular disorders, which you all know, the myeloma cast nephropathies, Fanconi's, but it's important to realize even the myelomas can cause functional disorders like TMA and C3GN. And this is, again, the full world of stem cell transplant and kidney disease. And you can see that that's very complex. While most of it's TMA, you do see other causes of AKI in the early stages and engraftment syndromes causing prerenal AKI. But in later stages, also see a CKD from glomerular diseases such as membranous and minimal change disease. So again, stem cell transplant is another whole area of onconephrology. And these are the glomerular diseases seen with onconephrology in stem cell transplant patients: membranous, minimal change disease, and FSGS. Dosing is another area in onconephrology that is seen with cancer drugs, with CKD and dialysis. Unfortunately, the data is so minimal. One of the big things we want to do as onconephrologists is to push the FDA and oncologists and drug companies to do trials in CKD and dialysis patients of cancer drugs, because it's very, very lacking at this point, and the data we get is very small studies and case reports of how we use some of these drugs in our CKD and dialysis patients. There are other subgroups that people are starting to do now: pediatric onconephrology, transplant onconephrology, palliative care onconephrology, and then cardiologists and nephrologists have combined together to form this whole oncohypertension component. So the late kidney effects of childhood cancers and cancer therapies is a big component of pediatric onconephrology, and I'm not going to spend too much time on that, but the pediatricians in the audience, this would be some interest if you're going into this field of onconephrology within pediatrics and nephrology. Oncohypertension is fascinating. We're seeing so much hypertension that following cancer targeted therapies, you can see here the degree, the incidence of hypertension with certain of these inhibitors, as high as 90% with VEGF inhibitors, as high as 53% in platinum inhibitors. PARP inhibitors have 19%. CNIs, we know, mechanisms are vastly different. Some are nephrotoxicity, some are angiogenesis decrease, some are endothelium mediated. And it's, the treatment is whatever you want to give technically, but most people give ACE, ARBs, calcium channel blockers, thiazides, and then, checking for cardiac involvement of LVH and things like that is important. So it is another whole growing field of onconephrology. And one of my other favorite areas is transplant onconephrology, managing a transplant patient with cancer and giving them immunosuppression at the same time, chemo or immunotherapy, managing some of the PTLD and those complications. I think that's just a fascinating area that requires a lot of growth and potential in the future. Palliative care in patients with cancer and kidney disease is a novel concept in the US. Palliative care itself is a novel concept, I believe, in India. It is now required for a lot of us to be in training to do some palliative care, and I think it's the right thing to do for some of these patients with cancer who have kidney disease or on dialysis. Is do we really need to give them chemo? Do we really need to give them aggressive therapy and really learn how to manage their symptoms, such as pain, fatigue, and things like that? So I think this is another whole growing area within onconephrology. So this is sort of a curriculum, that topics that should be given in perhaps a year of onconephrology, or if you had a few months of training, this is what things you should be covering in that. I only scratched the surface of the field, but I think this 2-day symposium, you are covering some of these topics. But I think seeing patients with these disorders, engaging yourself, getting to know the literature, really requires in-depth time to do that. What we have done is we have created a network of onconephrologists through a WhatsApp channel, and some of you are already on it. This was a study that looked at how that was doing when we incepted in 2019 to 21. It's a qualitative analysis. Now we're up to close to 250 participants, but we did a survey and keyword and thematic analysis, and we found that the most interesting thing was there was a good amount of mix of academic and older, younger nephrologists. Some people did have a onconephrology clinic, some didn't. Interestingly, after Up to Date, the WhatsApp chat was the next best resource to tackle tough cases and decisions. And the 3 quality themes that came out of this was collaboration, patient care, and knowledge sharing. And I think it continues to do that. And I think this can serve as a template for other subfields as well in nephrology, like just glomerular disease and so forth. So I think collaboration, patient care discussions, and knowledge sharing really came out of this creation. How do we educate people in onconephrology, right? There are what's happening in the US and Canada. So there are these extra years of fellowship that have been started by Sloan Kettering, MD Anderson, and Mayo Clinic. So those are places that are big cancer centers. Our place, we have a combined OncoNephrology and GN Fellowship, because sort of very related fields. And also UPenn has a similar thing. Toronto has also a year of OncoNephrology Fellowship. What we've also done is tracks within a regular fellowship. So when they're doing a nephrology training for 2 years, the second year you can pick a track, and some places that have leadership in this are doing that as well. And that kind of gives you a flavor to kind of go out and still practice onconephrology without doing an extra year, because it can be cost saving to some of the trainees. So ASON was founded in 2021. This was done to promote research, clinical activity, and education. And it was founded by myself, Shruti Gupta, Beru, and Arash. The discussion started in 2021, but really the development of the website, the logo, all took time, creating a 501c3 so it's tax exempt, and then kind of combining with the Journal of Onconephrology as the journal officially, and we started the officially in 2022 January. The features of ASON, anybody, it's just called American Society of Onconephrology, but really is an international society. People are coming from all around the country to join. Education, research, position statements, websites. There are a lot of committees you can get involved in, partnership with industry and ASCO, monthly educational series, and you've seen some of that on Twitter. And we also help kind of host the annual Onconephrology Symposium. The last one was done in Sloan and MD Anderson in Texas. This year it's going to be at Sloan Kettering in New York. But what about oncology and onconephrology in India? So again, cancer medicine, again, affordability in India is a big issue, but people are getting these new drugs and are seeing cases of onconephrology complications. But experts in India in onconephrology, where do we stand? I think you're still in the inception stages, what I understand talking to people, but the fact that you're having these conferences suggests there's a lot of interest. There is a lot of great vibe to move this forward. And I saw this article by Trivedi and Nair in the Indian Journal of Nephrology that really kind of takes exactly what we should be doing, taking your strengths, weaknesses, turning into an opportunity, and keeping the threats in mind when you create onconephrology in India. I think there is a lot of strength in the power of India and the manpower and the great nephrologists that you all are. As you see, most nephrologists in the US are Indians of Indian origin, so it all comes from you guys. There is, there's some infrastructure issues that need to be figured out. There's a lot of opportunity, but you have to keep the threats in mind. So I think the 3 ways to succeed for onconephrology in India come threefold. There has to be awareness, there has to be training, but then we have to keep in mind the threat or the opportunity. Is there a need? Is there a supply demand for it? Okay, I think that's very important. So conferences, seminars, doing joint ISN sister programs, joining with ASON, ANIO initiatives, doing CMEs is increasing awareness. Creating experts to teach and promote the field is so key. When I was learning to be an ultrasound expert, once I become the expert, then I can teach fellows, right? You need to create experts first before you move to the next level. So the first stage is to create experts. That takes time. You can, a country like India with so many billions of people living there, you need more than just 5-6 people. You need, a lot of experts to promote the field. Then you create the centers of excellence that can provide that expertise and the next step of training. Okay, training is the next part. So I understand there are 2 pathways in India to become a nephrologist. You do something equivalent of a US-based fellowship, which is a DM or DNB. So could you create tracks within your nephrology training for people interested to become onconephrologists, or at least have that interest and expertise within general nephrology? So that's one way. But to have those tracks in your training, you have to have experts to give those tracks sort of heading those tracks, right? So that's why you need to first train the experts, maybe externally, or you just learn from the job. So additional training post DM or DNP, maybe a 6-month or 1 year in India or abroad, is one way to get those experts to come and then go back and do the tracks within India. But again, this is something we can discuss how this is possible within your country. But then we have to keep in mind the supply and demand. In US, there is a lot of demand, a lot of rising cancer centers, and the oncologists call consults all the time. There is a consultative based model in the US to make money in a way. In India, I don't know how that works. Do the hematologists, oncologists call nephrologists often? Is there a demand, or are they just treating by themselves and taking care of most of these things? Is there ample volume to sustain a practice to just do onconephrology and not do general nephrology? Then there is the whole debate about should be just academia or private practice. Can they both flourish being an onconephrologist? So those are things we need to answer before you go jump into doing things and building programs. And I think this discussion hopefully will answer some of those questions before we move into the next phase of onconephrology in India. So I think I'll end with that because I think we're going to really have some question answers and discussions for the remainder of time. I really want to thank my division and my pathologists, my mentors from Sloan Kettering, and all the collaborators around the world that really make me excited about this field. But anytime you have questions, email me. But let's chime in for more questions now that we are done with the official presentation. Thank you.